Yes, we are live.
Shall we start, Arun?
Yes, let's start.
Okay. So a warm afternoon to everybody. This is Jayashree from Janitri Innovations, and I take care of the business in Tamil Nadu. With great, immense happiness and pleasure, I'm very happy and very proud to host this webinar today on intrapartum surveillance. So herewith, we have Dr. Vijaya and her team, so who will be taking us through this session of the intrapartum surveillance. And we have Dr. Sharmila, who will be taking the intrapartum fetal surveillance, and Dr. Balaji, who will be taking care of the intrapartum maternal surveillance. So both Dr. Sharmila madam and Dr. Balaji sir, they are the senior assistant professors of IOG in Chennai, which is a great organization located in Chennai. Over to you, Vijaya ma'am. So please enlighten us with your words, ma'am.
Hi everyone, good afternoon. Am I audible clearly?
Yes, ma'am, you are.
Yeah. So I bring greetings from my own prestigious premier institute, one of the biggest in Southeast Asia, the Institute of Obstetrics and Gynecology, Government Hospital for Women and Children, which caters to more than 18,000 deliveries per annum. So they see the percentage and the popularity of our hospital. So the monitoring and the surveillance is very, very important in our hospital. To come to the topic main, this surveillance basically needs a teamwork, a shared responsibility, a definite guidelines, and in-house training periodically, so that be it an obstetrician or a staff nurse or an A&M, whoever is looking after the delivery protocol, they should be well versed in the guidelines. They should not be deviate from the guidelines. That's what I just want to stress. And antepartum fetal surveillance always looks into prevention of stillbirth, the death of the baby inside the utero, whereas the intrapartum fetal surveillance mainly caters on preventing the perinatal asphyxia. So it's very, very important. We should have a healthy mother and a healthy baby, and the mother should go with the baby with a good milestone, and there is no possibility of HIE, no possibility of any brain damage. That is what we all are strive hard every day in our duty. And you all very well know, no surveillance is 100% perfect. There are flaws and there are advantages and disadvantages. There will be practical feasibility, practical difficulty. So to highlight all this issue, I have great pleasure in introducing my assistant professors, Dr. Sharmila and Dr. Balaji, who will take you to this journey of intrapartum surveillance in a smooth, sailing manner. And over to them. Thank you so much for the opportunity.
Thank you, ma'am. Thank you so much. Herewith, I'm very happy to have Dr. Sharmila, madam, and Dr. Balaji, sir. Over to both of you, sir and madam.
Yes. Am I audible?
Yes, ma'am. Yes, ma'am. Can you?
Yeah, I'm sharing it.
Yes, ma'am.
Are the slides visible?
No, ma'am. Yes.
Is it visible now?
No, ma'am. You can open your presentation and keep, and then you can open the Zoom, ma'am. Open your presentation and keep, then open the
Yeah,
Zoom.
I've done that. Are my slides visible now?
Yes, ma'am. Yes, ma'am. Yeah.
So I extend my warm greetings. The webinar or intrapartum fetal surveillance. I hope and we will keep up, madam, surveillance by our team. So today, my points of concern are going to be these. So main goal in intrapartum fetal surveillance is timely identification of the fetus that are being inadequately oxygenated to enable appropriate action and reassurance of adequate fetal oxygenation to avoid unnecessary obstetric interventions. Response to hypoxia. So whenever there is a decrease in the placental blood flow, there is reduction in the gaseous exchange, which in turn leads to carbon dioxide accumulation, leading to respiratory acidemia and fallen pH. So this respiratory acidemia is a part of normal delivery. It emerges rapidly and does not produce major insult to the fetus. Whereas on the other end, the reduction in the fetal oxygen saturation and increased lactic acid leading to metabolic acidosis, however, requires time to develop. Once developed, it remains and produces 20% of cerebral palsy and 20 to 40% of stillbirths are due to intrapartum asphyxia, and around 25% palsy are due to antenatal causes. According to ACOG and AAP, intrapartum hypoxia is sufficient enough to cause features of umbilical artery pH less than 7, 5-minute Apgar scoring less than or equal to 3, moderate or severe neonatal encephalopathy with multi-organ birth asphyxia. So the most commonest causes of intrapartum asphyxia being maternal hypotension, maternal hypo and hyperventilation, cortical insufficiency, and abruption. So these are the various methods of intrapartum fetal monitoring system. However, the most common in use are being intermittent auscultation and electronic fetal heart rate monitoring. So according to intermittent guidelines on intrapartum fetal monitoring, intermittent auscultation is to be done for a duration of 60 seconds and for 3 countries the normal range. It is to be timed during and at least 30 seconds after a contraction at a frequency of every 15 minutes in the second stage, and however in 30 minutes and 15 minutes in a low risk pregnancy, along with fetal heart rate monitoring, uterine contraction and maternal heart rate are also to be monitored. So these are the following conditions where considering and maintain is required in settings where CTG is available. So normal frequency of contractions, no induction or augmentation, vaginal hemorrhage, no meconium, no maternal fever, active first stage less than 12 hours, second stage less than 1 hour. So these conditions available with you, you can recommend intermittent auscultation. So this was a RCT done in Muhimbili National Hospital from 15, comparing the intrapartum fetal heart rate monitoring using Doppler and Pinard stethoscope. Here, 44 women, term women, antenatal women were considered in this study, and it concluded that Doppler detects more abnormal fetal heart rate patterns of decrease in the incidence of stillbirth or neonatal death. So when do you switch over from intermittent? These are the few indications. Maternal indications being maternal tachycardia, maternal medical disorders, fever, induction or meconium, any delay in the first and second stage of labor. Fetal indications include reduced fetal movements, oligohydramnias and hydramnias, and suspected intrauterine growth restriction. So this was a review of 13 trial studies, including around 37,000 of pregnant women in labor, which compared intermittent auscultation with continuous including both low risk and high risk women. So in this, CTG was associated with low risk of neonatal seizures outcome. However, C-section and operative vaginal deliveries were higher. Electronic fetal monitoring, or it could be continuous electronic fetal monitoring. Though continuous electronic fetal monitoring in low risk, it however stays mainstay in the management in many countries. Cardiotopography, it is a technical mean of and the intrauterine pressures during labor. So the components of the machine includes the cardiac probe, which records the fetal heart rate, uterine contractions, the fetal movement counter. So based upon the placement of the transducers, it could be external. That method, it is a non-invasive one, whereas internal being more accurate direct method and invasive one. To conditions like signal losses, where it can lead a faulty recording of maternal heart, signal artifacts, where it leads to doubling of the fetal heart rate or half the amount of heart rate could also be recorded. Fetal monitoring in twins. So it is advised to have 2 cardiac probe in recording the fetal heart. And it is usually the second fetal heart rate is being set at a plus 20 beats per minute. But in settings where only 1 cardiac, you could do it in 2 different instances, but care should be taken. The other fetus should not be left unmonitored. And innovation, telemetry. CTG acquisition can be performed by portable sensors that to remote fetal monitors. So in such conditions, patient can ambulate well and it's more comfortable for the patient. It shows maternal pulse rate, ST analysis, etc., which we are going to see in later slides. Setting up of CTG. So of the CTG machine should always be standardized before we start upon any putting up a CTG for any of the patients. So date checked before you start, which is going to act like a medico-legal record for future references. And the paper speed should be set to 1 centimeter. Paper speeds to 2 centimeter or 3 centimeter per minute. 3 centimeter per minute paper speed gives us more accurate. We're all more familiar in interpreting CTGs with 1 centimeter per hour per minute, and it produces heart rate patterns. And of course, it's going to give us reduce the tracing length. The sensitivity display should be set at 20 beats per minute. Rate range should be from 30 to 240 beats per minute, and RCOG recommends the same. Reliability of CTG, 87% and specificity is 66% and has a high negative predictive value of 92%. A normal CTG, abnormal CTG recording abnormal outcomes. Most fetal heart abnormalities are not associated with acidemia, and most neurological disabilities. So when you come to the interpretation of CTG, these are the 5 components which we are concerned of: the uterine heart rate, baseline heart rate, fetal variability, and accelerations and decelerations. Coming to uterine, the number of contractions, how long does the contraction last, how frequent are these contractions lasting, the intensity, and the rest. Baseline fetal heart rate. Baseline fetal heart rate activity refers to the modal characteristics that prevail apart from the periodic acceleration associated with uterine contractions, the normal being 110 to 160 beats per minute. Anything above this or below this could be labeled as tachycardia. Commonest causes of tachycardia are fetal hypoxia, chorioamnionitis, fetal tachyarrhythmias, fetal hyperthermia, drugs. Bradycardia is more common in head compression, cord compression, congenital heart block, and corporal. Baseline variability is a sympathetic and parasympathetic push or pull mediated via the sinoatrial node that produces moment-to-moment of the baseline heart rate. However, the baseline variability could be reduced in normal conditions like prematurity. It is reduced in hypoxic babies. Depending upon the amplitude of these fluctuations, the baseline variability are being graded as absent, marked, or sinusoid. Abrupt increase in the fetal heart rate for more than 15 beats per minute and lasting for 15 seconds is labeled as acceleration. Accelerations coinciding with uterine contractions, especially in the second stage of labor, you must be watchful at that time. Say, maternal heart rate as it has been shown in this slide. Decelerations could be early, late, or variable. Are most commonly seen in head compression. Here, the peak of contractions coincides with the nadir of the deceleration. And here, the deceleration usually starts around 20 seconds after the peak of contractions, and it occurs in gradual. It requires more than 30 seconds to reach the nadir. It is mainly seen in uteroplacental insufficiency, which is mediated by baroreceptor to increase in arterial pressures. Next is variable deceleration, which is it is abrupt fall in fetal heart rate, and it also baseline and same nature. It is mostly seen in umbilical cord compression, which is a baroreceptor mediated response. Acceleration before and after variable deceleration is called shouldering, which indicates a healthy fetus. It is mainly because of the compression of umbilical before the umbilical artery and sequential relief of the vein followed by the umbilical artery. So when you have absence of pre-acidemia, sinusoidal pattern, a regular oscillation of fetal heart rate, of the baseline heart rate, resembling a sine wave. Most of the causes of sinusoidal patterns are severe fetal anemia seen in RH isomerase hypoxia. So pseudosinusoidal pattern is something which resembles sinusoidal pattern, but more with a jagged or sawtooth appearance. So these are more common in following analgesia to the mother, fetal sucking, or mouth movements. So this pseudosinusoid occurs for a short period of time, that is maybe for 10 minutes, and it is being followed by a absolutely normal fetal heart rate pattern. CTG, we follow this mnemonic, Dr. C. Bragdo. So all these parameters should be interpreted. Baseline rate, accelerations, variability, deceleration, and an overall impression. So whenever you describe, when you're describing the features in the trace, if the features individually has to be described as reassuring, non-reassuring, or abnormal. CTG trace as a whole, it has to be interpreted as a normal, suspicious one, or a pathological one. CTG interpretation, I would like to brief you all on intrapartum hypoxia. So the types of intrapartum hypoxia to gradually evolving hypoxia, subacute hypoxia, or an acute hypoxia. So this chronic hypoxia is mainly because of antenatal period. So it follows a CTG pattern of reduced variability and shallow deceleration. It associated with this is around 39%. And whenever you come across such a CTG or a chronic hypoxia pattern, you have to turn within immediate as you see this pattern. Second thing is gradually evolve occurs over a period of hours. So it initially starts with deceleration due to the reduced myocardial workload, followed by loss of fetal movements, leading to tachycardia because of catecholamine release, followed by reduced baseline variability with a decompensation state, leading to decompensation state. So this hypoxia is an effective compensatory response. It could be seen when you and when you come across such kind of CTGs, you have to deliver the patient within an hour. Yeah. So the time spent here for the fetal heart rate in the baseline is less when compared to the duration in the accelerations. The deceleration second stage or injudicious use of oxytocin can lead to this. And subacute hypoxia, once you have when you need to deliver the baby within 30 to 45 minutes. Acute hypoxia. So this is prolonged deceleration or terminal bradycardia, mostly associated with conditions like abruption, cord prolapse, and rupture, uterine rupture. So when you come across such conditions, so immediately plan a delivery within 15 to 30 minutes. And this can actively damage the brainstem and lead to cerebral palsy. Coming to clinical guidelines, where there are various guidelines in detail with FIGO. So this category, interpretation using these guidelines, baseline heart rate, variability, and deceleration. Acceleration does not come into these in this as a criterion. So the CT, when the baseline heart rate is around 110 to 160, variability is between 5 to 25, no repeated decelerations. In such condition, CTG as normal, there is no fetal hypoxia, so no intervention is required at the present moment. It could be labeled as a suspicious trace when absent, and provided there are also no pathological features. So then this is being labeled as suspicious trace, and the hypoxia. Actions are taken to correct reversible causes. Once identified, correction should be done, and close monitoring is advocated. Pathological, in the baseline fetal heart rate is less than 100 beats per minute, reduced variability, increased variability or sinusoidal pattern for more than 30 minutes. And it is associated with a repetitive late or prolonged deceleration for more than 30 minutes or 20 minutes if reduced variability. In a single prolonged deceleration for more than 5 minutes. So in this condition, the fetus has a high probability of having hypoxia. So immediate actions should be taken. This is not possible, expedite delivery, especially in conditions where there's a cord prolapse, uterine rupture, or abruption placenta. Immediate delivery should be. So this is just a comparison of FIGO, NICE, and ACOG guidelines. How do they classify the various? So this was a study which was conducted in 2017, where around 151 tracings were evaluated by across USA and UK. They have come to a conclusion that ACOG's guidelines has a high overall interabsorber with a low sensitivity and high specificity of category 3 tracings in prediction of fetal acidemia. Whereas FIGO and NICE classification, and there appears to be higher sensitivity with a low specificity of pathological tracings in prediction of fetal acidemia. Person compared intermittent fetal electronic fetal monitoring with continuous electronic fetal monitoring. Intermittent electronic fetal monitoring was very much found to be as effective as continuous electronic fetal monitoring in low-risk labors. So Bex et al. Concluded women with admission CTG were more likely to have continuous electronic fetal monitoring, fetal blood sample, and C-section, although there was no difference in the neonatal outcome. Hence, routine admission CTG is not recommended. Rate monitoring are fetal scalp blood sampling, stimulation test, and fetal ECG. So whenever you see a suspicious or a prolonged CTG, we could subject them to fetal scalp blood sampling. So these are the guidelines for interpreting scalp blood pH and lactate levels. When the pH is more than 7.25 and the lactate levels are less than 4.2, it is in at that moment. And when the pH value is between 7.22 and 7.25 and lactate levels between 4.2 to 4.8, acidic state, and repeat lactate levels are being advocated after 30 minutes. When the pH is less than 7.2 and lactate of more than 4, and delivery has to be planned. So comparing scalp lactate levels and pH levels. So this lactate level, the type of acidosis, whether it is metabolic or respiratory, sample required is very less when compared to the pH sampling. It takes less, it's technically easier. Whereas fetal scalp pH monitoring, it identifies only the presence of acidosis compared to lactate levels. Has to be, the sample has to be taken to the lab for processing, and it requires approximately. Clotting could, however, delay the results. So this slide is going to show you the significance of fetal heart rate changes. So when you look into the 8th, 9th, and 10th fetal heart rate patterns, that is late deceleration, loss of baseline variability, acceleration, excluding fetal acidosis. Failure of acceleration does not always mean centers where fetal blood sampling is being done. FSS reduces its need by 50%. An electronic artificial larynx is being placed directly or about 1 centimeter from maternal abdomen, and a sound pressure is being delivered. Normal if there is acceleration for about accelerations. And however, this testing, it reduces the testing time of CTG and or enhanced labor management. So this was a study which was conducted in 2002, Intrapartum fetal stimulation. So it was concluded that all these tests are useful only to exclude fetal acidemia. None of them were predictive of neonatal outcome. Is a good predictive response compared to fetal scalp puncture. And when acceleration response does not occur, scalp blood sampling should be considered. So ST analysis, STAN, a special fetal monitoring device that combines labor using a scalp electrode. So this reduces the need for fetal blood sampling, reduces the need of babies developing. However, there is no difference in the neonatal outcome. So this is the trace, the monitor of STAN. Tells us the association of T waves with the QRS complex and also the ST segments. So STAN alerts are in the form of episode T QRS ratio, baseline rise, or recurrent biphasic ST segments. So these are the interpret the condition with ST analysis. So depending upon the fetal heart rate patterns, it is being classified, and along with the fetal heart rate patterns, the occurrence of ST segments saturation by placing an electrode on the fetal cheek. The normal fetal saturation is around 30 to 70%, and along with abnormal fetal heart rate pattern, it indicates fetal acidemia. It has a specificity of 38% and sensitivity of 94%. It includes 7 trials with the participants of 8,013, published in 2007, concludes there was no effect in computerized assessment of fetal monitoring. So this continuous CTG during labor fed it automatically So when there is fetal hypoxia, there are both visual as well as sound alerts alarming us. And the main aim of this is to C-section rates. So these are the various alerts. So when the CTG fetal heart rate pattern is met with the normal criterion, and there is pre-terminal CTGs or very pathological CTG patterns, the red alerts are being given. So there are two trials. The infant trial included 46,614 laborers and around Ireland was involved in the study. So decision support software were used to analyze the CTG, and it concluded that it did not improve the trial, which was conducted in UK around in 5 maternity units, compared computer analysis with visual analysis of CTG. Was metabolic acidosis rate was reduced with computer analysis. So, however, to conclude, it's very much required to diagnose the underlying cause for the suspicious or pathological CTG. Get back, check for the reversibility, assess the clinical situation, and then form your action plan. But our intrapartum fetal surveillance is to identify the state which precedes hypoxia with minimal obstetric or minimal. So try to correlate fetal heart rate patterns to physiology and never try to comment such patterns, comment just as patterns. My thankfulness and gratefulness to my director, Dr. Vijaya, supporting for all our presentation in such forums. And definitely I would also extend my gratefulness to my who's the deputy director of the institution, and also to my associate professor, Dr. Vita, who had extended their personal support into my presentation. I also thank my postgraduates who had helped me out with this PPT. And last but not the least, I would like to thank Intrapartum fetal surveillance. Thank you all.
Thank you, ma'am. Thank you so much. It was a wonderful session. So about the ST analysis and all those things, the sensitivity, specificity, all those values which you shared. Really, ma'am, it's of super significance to us. Thank you so much, ma'am. To go on with, so there is a presentation from our side. So like I'm doing a presentation. So myself, I'm introducing me again. So I'm Jayashree, so taking care of the business in Tamil Nadu for Janitary Innovations. So to start on with, let me share my screen first. So is my screen visible?
Yes.
Okay. So our vision and mission is like innovations to save lives at birth, be it maternal or be it the infant. So that is our major motto. So to go on with, there are a lot of challenges which we generally face during labor. So be it the maternal death, be it the fetal death, we do not know what exactly is happening. And we at Janitary Innovations, we have done a lot of research and we have got a lot of technologies, new inventions to reduce the fetal mortality and the maternal mortality to a great extent. To go on with, of 2 million neonatal births, 250,000 maternal death actually happen during intrapartum, and more than 70% of the deliveries that they generally occur only in a low resource healthcare setting where there is no proper doctors available or proper nurse concern available. There might be a situation where there is no proper equipments to monitor. So those are the major reasons. And if you see, there are almost 9 lakh intrapartum related neonatal deaths, that is fetal distress is not being seen at a very early stage. It's not being picked up during labor. So see, if we take the main thing is FHR and uterine contraction are the more important parameters for early detection of fetal distress. So which we generally monitor during the intrapartum period. And this will not be possible if we don't have a proper medical device and if the patient or the staff ratio is not proper. Then the FHR and the uterine contraction are to be monitored regularly and accurately. So if we don't monitor it for some period of time, then obviously we might get flaws in the results. So the existing technology which we have is a CTG, cardiotocography, and Sharmila madam has given a lot of information on CTG, like how does it work and what is the sensitivity, what kind of accuracy it gives, and all those things. To start on with CTG, first thing, it is not affordable. It's a little costly. Second is it's not portable. Like the machines are a little bulky and it is not easy for the patients to carry it with them and go here and there. That is first thing. Second thing is it is not a patient user friendly kind of thing. To stress on this point, see, when we use the CTG machine, we require a skilled healthcare worker, a skilled person, so that she places the sensors properly, the sensors pick up the values properly. So all those things are required. And many patients don't feel comfortable if they use a CTG machine. They are able to feel that kind of weight. And the second thing is patients cannot move. The mobility of the patients is being restricted. So with all these disadvantages, we have come in with the remote monitoring technology. And if you see the output the CTG gives, first thing, it is not easy to use. So every time you have a paper, you have to give care and give the paper. There is no proper storage of those data. That is first thing. And second thing, to interpret a CTG report, we actually require a skilled healthcare professional so that she sees it, she tells, okay, this is good, this is bad, this is not at the proper level. So there might be some issues with some issues like tachycardia, bradycardia, and there are a lot of fetal problems. So we need a skilled healthcare worker. Second thing, there is no data transmission for remote monitoring purpose. For example, if a doctor is at home and she has a labor happening in the hospital, there is no way that she can monitor that patient sitting at her home or sitting at her OP. That is not possible. Every time she has to go check whether the patient is normal, everything is happening good, the nurses are taking good. I mean, the nurses are taking care of the patient good, they are taking the values correct. So all those things are there. So with all of these disadvantages here and there, we have come with the remote monitoring technology at Gen3 Innovations. Going forward, our device KR Pro, so which is an advanced fetal monitoring device in application. First thing, it monitors the fetal heart rate, it monitors the maternal heart rate, it monitors the uterine contraction, and it is mainly used for the intrapartum monitoring, postpartum monitoring, and it can be also used for continuous monitoring. So in continuous monitoring, what do I tell is the patient can, she can carry the device along with her and she can be continuously monitored for a long time, unless CTG, where if she moves or she goes somewhere, the machine has to be disconnected, then it has to be reconnected. So that problem and all is not there in our machine. Going to next one. So our KR is a portable fetal ECG and uterine EMG based fetal and maternal monitoring device. So it uses the ECG principle and the EMG principle. I mean the fetal abdominal ECG principle and the EMG principle to give the fetal heart rate, maternal heart rate, and the uterine contraction. So the monitoring becomes effortless, it becomes portable, it becomes wireless, and you can have complete patient mobility in that. To go on with fetal heart rate, maternal heart rate, and uterine contraction monitoring is possible. This is a single time patch placement method. So where unlike CTG, you need to change the belt position here and there based on the baby's movement. That is not necessary. It's a single time patch placement. And the third most important thing is it is a long-term continuous patient monitoring. So like, it's not like you have to disconnect the machine, then reconnect it. No. So it can be used for a long term. So almost 24 hours, you can continuously monitor the patient. So we give that kind of facility in our product. So going on to the second is Daksh. So Daksh is nothing but it is our complete labor monitoring tool, which we have built to save the time of the medical professionals. Like the Daksh actually it has inbuilt alerts and alarms, and it notifies the users if there is the increase in or decrease in the fetal heart rate, maternal heart rate, cervix dilation, and all those that. And apart from that, it also has e-pactographs, and it also generates patient case sheet. So to sum up with few quicker points, Daksh has an automated e-pactograph, it has remote monitoring, and it has a digital patient case sheet. So that is that. Next to go on, in Daksh, we have the dashboard and the central monitor. So what is the dashboard and the central monitor is that? So it allows the admin people or the doctors to have access to all the patient data, which can be the doctors or the admin people, they can access the patient data remotely. So that is the major point in that. So the central monitor will actually display the fetal heart rate, the uterine contractions of multiple patients at the same time. So it has a centralized monitor. It also gives remote monitoring, and you can have access to the complete patient data. So that comes with the dashboard and the central monitor. Going on, so how does KR and Daksh? So KR is our product and Daksh is the app. How these two combine and how do they deliver and how do they help in monitoring labor? First thing is a patient arrives. So when the patient arrives, we connect KR device and the patch on the patient. So once we connect it, we add a patient. So we add a new patient on the Daksh app, which is available in the tab. Then once the patient is added, then we start monitoring the patient's vitals like her fetal heart rate, maternal heart rate, uterine connection. So we connect the KR device to the Daksh app and do the monitoring. So once monitoring is done, the patient delivers. So once the patient delivers, the Daksh has three parts in this. You have an intrapartum tab, you have a postpartum tab, and you have a completed tab. So once the patient delivers, immediately she's moved from the intrapartum tab to the postpartum tab. So she goes to the postpartum care. So continue with timely monitoring till the patient is discharged. So when the patient enters into the healthcare domain for labor and still she delivers, we can have a complete entire case sheet of her available. So that's one of the major significance of this Daksh app. So why fetal ECG and why uterine EMG? So first thing is our device KR, it is a beltless experience. So where the ECG, fetal ECG and uterine EMG based technology is used for monitoring the fetal heart rate and uterine contraction. So it has no concept of belt in that, so that the patient can be completely mobile during her labor. Second thing is, unlike the CTG where there is a data loss or there might be wrong interpretation of data because of the baby's position, this is not like that because we have a ECG, like we get the fetal ECG, we get the maternal ECG, we have various algorithms to discriminate the fetal ECG and the maternal ECG. And unlike using a TOCO principle for monitoring the uterine contraction, we use the EMG principle where the data we get is more accurate. Second thing is why am I mainly talking about this? If you use an ultrasound technology, the CTG uses ultrasound and TOCO principle. So what happens in ultrasound technology is patient's BMI is a disadvantage. Second is we do not know the baby's position properly. So if we use an ECG and ECG technology, the abdominal ECG technology to get these values, this is even more accurate than the CTG values which we get. Going on single time placement. So as I told you already, so unlike CTG, so we can place the electrodes at only one time. Then the position of electrodes need not be changed at all. So this is one of the greatest advantage which we are providing. And clearer signal differentiation. See, the nature of technology which we use to isolate the fetal ECG and the maternal ECG signals are like, it's very better. So we actually differentiate the QRS complex of both. Now the fetal heart rate and the maternal heart rate are getting differentiated from the fetal ECG and the maternal ECG. So it does not get mixed like in Doppler technologies, we have a lot of mixing of data, which generally doesn't happen with us. Third, this is data of a 39-week lady. So we have our data here, and this is the CTG data. So you can see how accurate our data has come. And this was actually, was done at Rangadore Hospital in Bangalore. So, and this is a uterine contraction data. So this is the KR data, and this is our CTG data. You can see the stiff peaks also happening here. So here, the technology is more accurate, so the values are more reliable and more accurate. Finally, actually, when Sharmila madam went through her presentation, she told about this TAN analysis, so ST analysis in labor. So where this acceleration, deceleration, short-term variability, long-term variability, there were a lot of things madam was talking about. And we get a report like this, where we have a baseline, we have acceleration, deceleration, contraction, mean, baseline heart rate, short-term variability, long-term variability, standard deviation. So everything is automatically computed by the device, and it generates the report in your mail ID. So this is one of the significance, and this is one of the best output we have. Going on with, I have a small video to be played. So let me play it.
Jashri, voice is not coming.
1 second.
More than 99% of these.
Is it coming now?
Yeah.
Developing countries. And if you look at the India's number, we have only 60,000-70,000 OBGYNs, over 3 crore deliveries per year. So you see that mismatch. So who are doing these deliveries? These are the staff nurses, midwives, ashas, guys. So Charitri is a Sanskrit word of mother. We are working with a vision to see a world where no mother or baby die during pregnancy, delivery, or post-delivery. So for KR, which is an affordable and easy to use, wearable fetal heart rate contraction and maternal heart rate monitoring device, which communicate wirelessly with our touch intelligent mobile application for intelligent alerts and remote and central monitoring, which helps the overall stakeholders like staff nurses, midwife, doctors, obstetrician, government, in reducing the overall mortality, morbidity in labor phase.
If a lady is laboring in a peripheral area or rural, remote rural areas, and if this machine was available, fetal and maternal surveillance both become quite easy. So the obstetrician has the advantage of even sitting at home, monitoring what's happening with the traditional CTG, she is tied to the machine, so she cannot mobilize. Mobilization is very, very important during it becomes hard for us to monitor the baby if the posture is since just something decentralizes the care, but centralizes the monitoring and also the decision.
If you go to African countries or South America, India, by just having this like training, we use it. So scalability is one thing, and is it easily used as its scalability is another angle, because if you look at the number of hospital settings, so it should be able to.
Yeah, Jashri, can we move to the next session? Can we move to the next session?
Yeah, thank you. Thank you to all, and over to you, Balaji sir. So next session will be intrapartum maternal surveillance by Dr. Balaji.
Hello. Am I audible to all?
Yes, sir.
Good morning. I can call this as good afternoon, right? First of all, I would like to thank the audience who have connected to this session. I hope that various levels of audience would have been connected in this, like paramedicals to senior most professors. So kindly bear with me that I may be a little basic somewhere and informative somewhere. And I think let us go into the topic because it's nearing the lunch time. First, I have some introductions about where we are. That means where we are sitting actually. This is our hospital, Institute of Obstetrics and Gynecology, where we are sitting here. And it is 175-year-old. Why I am speaking all those things is we have some standards which are being maintained here. And I would like to share that standards also, which could be helpful for you who are just watching this. And this is our new building with our director. See, now you see a picture on the screen. It's a flight. What are we going to do with the flight? Are we going to conduct a delivery in a flight? That could be a question, but that's not that. Actually, you take this flight as the mother, the passenger as the baby, and the pilot as we doctors or paramedicals. The passenger sitting inside of the flight as such doesn't know who is driving it and what's happening and where are we going to land. Starting the session, starting the whole thing like pregnancy could be like loading inside the flight. And the very important is, as you all know, landing safely is very important. That's why we are here to discuss about the intrapartum surveillance. Hope my colleague Sharmila Madam would have spoken in detail about all the fetal monitoring. I would like to emphasize certain points on maternal monitoring, like speaking about the flight. What's happening around us? Only with knowing that we can discuss why we are discussing this. The maternal death worldwide, these are the rates. The maternal death worldwide, it is 338 per 1 lakh live births, and in India it is 113 in 1 lakh live births. The perinatal mortality worldwide, it is 53 per 1,000 births, and in India it is 26 out of 1,000 births. The section rate, lower segmental section rate is worldwide, it is 24.7. In India, it is 40.9%. So what's our target? To achieve this target, we should have certain standards so that we decrease the maternal mortality, the perinatal mortality, and reduce the section rate also. Our target by 2030 is the maternal mortality rate should fall from 113 to 70, and our perinatal mortality rate should fall from 26 to 12, and the section rate should fall to 10 to 15% by 2030. But this was released by 2020. This goal was released in 2020, that what we are going to achieve in 2030. So what are we going to discuss today? These are the topics which we are going to discuss today. Partograph. Hope everybody will be well versed with partograph, but it has to be discussed, yes, because of the types of audience. And the amendments in partograph, which has been done long since from 1954 to the current 2021. And we have different varieties of type partographs also. Ultramodern usage of ultrasound, intrapartum, and maternal monitoring is also there. Partograph, as you know, it's a graphical record of the observation made by a woman for the progress of the labor. Progress of the labor and the conditions for the mother and the fetus, which we all know. Small history, it was found out by Sir Friedman in 1954, and he developed just a S-type curve where he showed that latent phase and an active phase that could have been differentiated into a deceleration and acceleration phase. But the things we have to remember is it's an S-type curve plotted against cervical dilatation and the time limit. This is the basic of all the photographs even today. So next came Philpott and Castle, who added the alert and action line in 1972. The alert and action line, there were different discussions between them, where to start that alert line, where to start the action line. The alert line initially it was started in the previous things was 3 centimeters of dilatation. Now it has come to 4, it has crossed, and it has started now to 5 centimeters, whatever it is. The addition of alert and action line was done by Philpott and Castle Later on, this alert and action line was implicated in Nigeria, and they were arguing that initially they were arguing that it was 1.5 centimeter per hour. The dilatation was around 1.5 centimeter per hour. Then they said after adding this alert and action line, they said it is 1 centimeter per hour. And I would like to add a point in this. A well-known person, Professor Arulkumaran Sabaratnam Arulkumaran sir was one among this team to coin this alert and action line, and hats off to him. So now there are many changes had been made in WHO partograph. What are the changes made was latent phase has been removed. Initially there was a latent phase, now there is no latent phase. Latent phase should not last more than 8 hours. Active phase commences at 4 centimeter. Initially it was 3 centimeter. During active phase, the rate of cervical dilation should not be slower than 1 centimeter. A lag time of 4 hours between a slowing of labor and a need for intervention is unlikely. These are the changes made in the WHO partograph. This is the WHO partograph. You could see that the alert line starts from the 4 centimeters at 4 centimeters. Initially it was at 3 centimeters, and we had a latent phase also. That latent phase has been removed. These are the components of the partograph, where you see the details of the fetus, then the progress of the labor, then contractions of the uterus, the maternal status, and finally the investigation properties of the mother. Components of normal labor, you know already, it is a power, passage, and passenger. There are 3 P's. Now the components of the partograph, I'll make it as a fast presentation because it is well-versed thing partograph is. Fetal condition is indicated on the top, progress of labor at the middle, and the maternal condition at the bottom. Part 1, in the fetal conditions, this part of the graph is used to monitor the access of fetal condition. What is the fetal heart rate? Whether the membranes has ruptured? What is the nature of the liquor? The meconium or clear liquor? Then the molding and the presence of caput. This is the fetal condition at the top of the partograph. Next comes the fetal heart rate. More than 160 we call it as tachycardia, and less than 100 we call it as bradycardia. The membranes and the liquor is indicated there, like intact membranes, ruptured membranes plus clear as C, then ruptured membranes plus meconium stained liquor as M, ruptured membranes plus blood stained liquor as B, and ruptured membranes and abscess liquor as A. Molding of the fetal skull bones is also indicated in the partograph. Molding is an important indication where you see that overlap can for the fetal head to accommodate in the pelvis. Increased molding with the head high in the pelvis is a nominal sign for cephalopelvic disproportion. This CPD is assessed initially also, before labor also, and intrapartum also. It may change. So that's why we say that assessment of the pelvis during labor is important. Not that with just maintaining just calculating the fetal weight itself is sufficient. This may change due to various factors during labor also. So the separated bones we show as 0, bones just touching each other as plus, and overlapping bones as double plus, and severely overlapping bones as triple plus. Now the one axis it is shown as cervical dilatation, descent of the fetal head, and this section of the paragraph has its central feature a graph of cervical dilatation against time. So we have 2 phases: active phase, which begins at the 4 centimeter of dilatation, and it should have a contraction at least 3 contractions per 10 minutes, and each contraction should last for more than 40 seconds. The cervix should dilate at a rate of 1 centimeter per hour or faster. This has to be there in the active phase. Then only you can call this as an active phase. The alert line, you've seen in the graph, it is 4 centimeter away. It is 4 centimeter dilatation, represents the rate of dilation 1 centimeter per hour. Moving right to this alert line, you need to be vigilant. That a special care has to be taken. That is the indication and implication of this alert line and importance of this alert line. The action line can also be called as hospital line, and the action line is drawn 4 hours to the right of alert line and parallel to it. This is critical line at which specific management decision must be made. So now we'll come to the cervical dilatation. There is progression of cervical dilatation, which is also plotted in the partograph. Then the descent of the fetal head. It should be assessed by abdominal examination immediately before doing a vaginal examination, using the rule of 5th to assess engagement. The rule of 5, as you know, when 2/5 or less of the fetal is felt above the level of the pubic symphysis, this means that head is engaged. This is the single point which has to be remembered. When the 2/5 or less of fetal head is felt above the level of pubic symphysis, it means the head is engaged. Assessing the descent of the fetal head by vaginal examination, zero station is at level of the ischial spine that is shown in the picture. When the head, the denominator portion, when comes at the level of ischial spine, it is called as zero station. Then the photograph has the next part marking the uterine contractions. Observation of the contractions are made every hour, and we should know frequency, how often they are felt. And each square represents one contraction. Each square represents one contractions. How do we indicate the contractions? If we put dots in the contractions as a pictorial representation, that shows the contraction lasts for less than 20 seconds. If you put a slanting lines, then it shows that the contractions last between 20 and 40 seconds. And if you are fully shading the column, then it shows that the contraction lasts more than 40 seconds. Now, the next part of the photogram comes where you are writing about the details, what maternal condition details, name, date of birth, gestation, medical, obstetric issues, then what are the drugs, still what is the pulse, blood pressure, temperature, everything. So how to use management of labor using the photograph? In progress in active phase remains, if the progress in active phase remains on or left of alert line, do not augment with oxytocin. Do not intervene unless complications develop. And the point to be emphasized is ARM should be done any time in active phase. Whenever it is in active phase, you can go for ARM. At or beyond oxygen line. So the labor is prolonged. Conduct full medical assessment. Consider intravenous infusion, bladder catheterization. Deliver by cesarean section if there is fetal distress or obstructed labor. Augment with oxytocin by intravenous infusion if there are no contraindications. So oxytocin is used only if there are no contraindications. We can see some abnormal progress. When we call this abnormal progress of labor, one of the main functions of the photograph is to detect yearly deviation from normal progress of the labor. Moving to the right of alert line, this means it is a warning sign. Transfer the woman from health center to the hospital. When reaching the action line, this means there is a possible danger. Decision need to be on future management, usually by obstetrician or resident. Now we can see all these things. What you have seen is well known to everybody how to part a photogram, how to a pictorial representation photogram, which everybody almost they are following, right from the paramedical staff nurses and postgraduates and anybody who are attending in the labor ward. Now ACOG has given some guidelines for the labor disorders. It calls a prolonged latent phase, that is greater than 20 hours in nulliparous woman and greater than 14 hours in multiparous woman, should not be an indication for cesarean delivery. Slow but progressive labor in the first stage of labor should not be an indication for cesarean delivery. Cervical dilatation of 6 centimeters should be considered the threshold for active phase of most women in labor. Thus, before 6 centimeter dilatation is achieved, standards of active phase progress should be applied. Cesarean delivery for active phase arrest in the first stage of labor should be reserved for women at or beyond 6 centimeter of dilatation with rupture of membranes who fail to progress despite 4 hours of adequate uterine activity. When she fails to progress, even after 4 hours of adequate uterine activity, you take her for cesarean section. Then, where to decide for a cesarean section in the second stage of labor? A specific absolute maximum length of time spent in the second stage of labor beyond which all women should undergo operative delivery has not been identified. Before diagnosing arrest of the labor, we call the arrest of the labor when the dilatation is, the descent of the head is not there even after full dilatation. So that should be at least 2 hours of pushing in multiparous women, at least 3 hours of pushing in the nulliparous women. Longer durations may appropriate on an individual basis. Example, with the use of epidural analgesia, the longer durations can be managed. So the last point, which is important, is the manual rotation of the fetal occiput in the setting of fetal malposition. You can do the manual rotation of the fetal occiput also at the time of deliveries. So precipitated labor, we call it as precipitated labor when the maximum slope of dilatation of 5 centimeter per hour or more. Now, we have discussed about the partograph. Now we are coming to the electronic types of partograph. One among that is electronic partograph. The features of electronic partograph is full electronic capture of the patient information during childbirth, including CTGs, partograms, all labor events, outcome information, fetal blood sampling results, and part blood gases direct from the blood gas analysis. This information can show in the real time. That means this electronic partogram shows in a real time where you fix a probe and it shows the real time progress of the labor. It can be accessed anywhere, even sitting at home, you can access what is happening in the progress of the labor. Then comes the computerized labor management. This is something which to accurately and continuously measure the cervical dilatation. It is an ultrasound based where the ultrasound probe is fixed, and here also a real time monitoring is done. So this system provides accurate continuous measurement of the dilatation and the station. And it is a graphical representation of descent of the head, which is monitored by the ultrasound. Now the fetal monitoring system, which Madam has spoken in elaborate. So in partogram, we have to discuss about the current scenario of the partogram and what is happening in the partogram now. Here comes the latest guidelines and the latest updates regarding the partogram. Nowadays, though we say the partograph is very, very important for the management and intrapartum maternal surveillance, initially the evolution of partogram has shown that certain points had been missed right from 1954 and almost from 1990 to 2014, the section rate, LSCS rate is slowly increasing. And we could see that the section rate is more in the urban areas that we are sitting at Chennai here, like in New York or cities like Chennai or New York, the section rate is more than in the rural places. It's almost 28% higher than the rural places. And this has to be reduced. Not that a section should be taken off and every woman has the right to go for the section if it is really indicated. So comes this updation law of migration from partograph to labor care guide. You see a logo of wheel in this. That is the logo which is going to be followed hereafter in this by guidelines given by the WHO, which has to be followed in future. This is the essential physical researchers, competent and motivated staff logo. And this is a systematic representation given by WHO for, as we said, migration from partograph to labor care guide. The contents of this is respectful labor and child care, emotional support from a companion of choice, effective communication by a staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, then oral fluid and fluid intake, mobility in labor and birth position of choice, pre-established referral plan, and continuity of care. What is the similarity between the modified WHO partograph and WHO labor guide? Modified WHO partograph, it was coined around the year of 2012. After that, this labor care guide has taken its role, and it had made some amendments in the partograph, and there are some similarities between the previous partograph and this labor care guide. There are only two similarities. The graphical representation of progress of labor in terms of women's cervical dilatation and descent of fetal presenting part against time. This is similar. Formal, regular recording of important clinical parameters describing the well-being of the mother and the baby are similar. Now, what is the difference between the WHO partograph and the currently, which we are going to use, the WHO labor care guide? Active phase defined as starting from 4 centimeters of cervical dilatation. But this labor care guide says active phase defined as starting from 5 centimeters of cervical dilatation. This was made as a Jesus et al. Study who saw, it was done in Nigeria, who saw that the actual descent of the head doesn't start from the 4 centimeter and it started from the 5 centimeter of cervical dilatation. There was a small latent phase which was monitored during 4 to 5 centimeters. So the modified WHO partograph showed fixed 1 centimeter per hour alert line and action lines. Here it is evidence based. The time is not fixed. No second stage section is WHO partogram. Intensified monitoring in the second stage. No recording supportive care intervention. Explicit recording of labor, oral fluid intake and posture. WHO partograph records strength, duration, frequency of uterine contractions, but WHO care guide records duration and frequency of uterine contraction. It has left the strength. WHO partograph said no explicit requirement to respond to deviations from expected observation of any labor parameter other than cervical dilatation, alert and action lines. That means WHO partograph shows what to be marked, and labor care guide gives what else you can mark according to the situation of your own hospital. So that leniency is given in labor care guide. So what are the sections of the labor care guide? So this is the picture of the labor care guide. This is similar to partograph, but it is not like that partograph. It has many amendments which has been included. However, the alert line and action line has to be the same. And what are the sections of this labor care guide, which we are going to use now, and most of the hospitals have started to use this also. It is section 1 is identifying information and labor characteristics admission. Section 2 is supportive care. You can see that in the blue color thing. Care of the baby, care of the woman, labor progress, medication, and shared decision making. This is an extra point which has been added in the labor care guide, where they give a column like sharing the decision making. You can share the decisions with your superiors or somebody who is guiding you, or e-guidance, or whatever gadgets you are going to help of. Section 1, identifying information and labor characteristics at admission. It shows, the column shows the name, rupture of membranes, time, parity, labor onset. All these details are in the section 1. Wherever you know, you don't know the cause, you can write it as unknown. Guidance for completing the section 1. These are the components of the section 1. Name. Ask the woman her full name, record the woman's full name and verify that it matches the name on her medical record. Then parity. Extract medical records, the number of times woman has given the birth, and the parity is included. Use the local coding system to record parity. Example, P is equal to number of babies born. Then labor onset. Was the onset of labor spontaneous or induced? Record spontaneous or induced in the column of section 1. Section 1 also has active labor diagnosis. On what date was the active first stage of labor diagnosed? Date of active labor diagnosis. Use local format to record dates. Then ruptured membranes. On what date and what time were the amniotic membranes ruptured? If membranes have ruptured before admission. Again, the same comes here, date and time when all these things have happened. And you can record U for unknown. If the rupture of membranes is confirmed and the woman cannot report the date, she doesn't know when the rupture has membrane has happened, but you evidence and you see that there is a rupture of membrane, then you can write it as unknown. Then risk factors is also included in the section 1, where you are showing the known obstetric, medical, social risk factors with the implications of care given, like chronic hypertension, any other comorbid illness the woman is having. Now, the section 2. These are given as a sections in that partogram guide, labor care guide. Section 2 shows companionship. If she has a companionship, write it as yes, no, or no. Or woman declines, she has right to decline, and you write it as woman declines. Then pain relief, whether she needs a pain relief or she doesn't need. Now, the WHO is permitted to give a pain relief drug of pethidine 50 milligram IM as a single shot while she needs. And oral fluid, is she on oral fluid or no, or woman declines. Posture, what posture does she prefer? She wants to be supine or she wants to be mobile. The section 2 shows the companionship, pain relief, oral fluids, and posture. All these things I have discussed, the companionship, pain relief, what all it is shown in the section 2 of labor care guide. Oral fluid, if she is taking oral fluid, you can take a yes, no, or no. If you record no, encourage woman to take a light diet and drink as she wishes during the labor. What posture is the woman adopting during the childbirth? Supine or mobile? Includes walking, swaying, or any non-supine position, example, left lateral, squatting, kneeling, whatever position she wants. And if you record ASP supine, encourage women to walk around freely during the first stage of the labor. Support the woman's choice of position, left lateral squatting, kneeling, standing, supported by the companion for each stage of labor. Now there comes the section 3, as we discussed. It's a care of the baby. Now the first section showed the details of the mother. Next section showed the status of the mother. Then now it shows the care of the mother, care of the baby, sorry. Here it is indicated with FHR, fetal heart recording, whether no or yearly or late or variable decelerations, or which Madam previously discussed, and amniotic fluid status, fetal position, any accipita anterior and accipita posterior, then caput, then molding, which were in the earlier photograph only. So section 3 contains baseline FHR, FHR deceleration, amniotic fluid, fetal position, caput, and molding. So guidance for filling the section 3 is listen to the FHR for at least 1 minute. Then you can see in this column, this labor care guide is filled with definitely these 4 columns has to be there. First you assess, then record what to be recorded. Then you check, then plan what are you going to do. Take this as an example. Listen to the fetal heart rate for a minimum of 1 minute. Record the baseline fetal heart rate as a single counted number of beats in 1 minute. You get alert if it is less than 120 or more than 160. If the fetal heart rate is less than 120 or more than 160, ask a woman to turn onto her left side, then alert a senior care provider and follow the clinical guidance. This is the place where this labor care guide is giving you the preference that you can take the advice of the senior care guidance and you can follow the protocols of the methodology what you are following in your own hospital. They are not forcing you to do that and this. This is the way you're recording. Then what is the status of amniotic fluid? What is the status of the membrane? If it is intact or membrane ruptured, if it is membrane ruptured, meconium stain, then alert. When to alert? When it is thick meconium or blood stain. If blood stain fluid or thick meconium is present, alert a senior care provider and follow the clinical guidance. Definitely everybody knows what are the guidelines for a management of meconium stain like. Then the fetal position. It could be assess, perform a gentle vaginal examination. Then you record it. Occipita anterior, occipita posterior, occipita, what is the position? Alert if it is occipita posterior. Definitely occipita posterior, occipita transverse position is detected. Your guidelines may go into, you may take her for a cesarean section according to your plan of action. Then check for the caput to assess the cephalopelvic disproportions. Then molding. There also they have given if molding is 3+, alert a senior care provider for local body. If molding is 0 to double+, usual signs of normality. Reassess during next vaginal examination. Give some timing and reassess after 4 hours. As we do vaginal examination once in 4 hours, it is our routine. Then the section 4 gives the care of the woman: pulse, systolic blood pressure, diastolic blood pressure, temperature, and urine status. Like urine status, what you are seeing, proteinuria, trace, 1+, 2+, 3+. When a patient is having a systemic gestational hypertension, she may show 2+, and she may have a higher BP also. So to rule out the gestational hypertension, all this thing comes here. These are the guidance for completing the section 4, like pulse. When are you going to get alert? Like less than 60, more than 120, what you're going to do is given in that guide. Likewise, checking of the BP, the alert range is given less than 80 and more than 140. If that is more than 140, you recheck the BP, then you follow the guidelines of gestational hypertension. If the diastolic BP is more than 90, the same will be followed here also, like treating them as gestational hypertension. Then temperature, which is very much important in the case of membrane rupture outside, they may get into infection, which may, later on they can get into the scenario of sepsis, which has to be early monitored, and appropriate usage of antibiotics installation will come when you are alert with this temperature monitoring. Likewise, urine, as I already said, that proteinuria will show the systemic hypertension. Now comes the section 5, labor progress, contractions in 10 minutes, durations of the contractions, cervix dilatation and descent. This is similar to the previous paragraph, where you are monitoring the contractions, at least 3 contractions in 10 minutes, lasting more than 40 to 45 seconds, and the cervix dilatation and descent are plotted in the similar manner. So the guidance is given here, durations of the contractions. Alert if the less than 60 and more than 60. Then cervical dilatation, alert values are given more than if it is 5 centimeters more than 6 hours, 6 centimeters more than 5 hours, 7 centimeters more than 3 hours. These are the things we have to take an alert, and accordingly you should monitor. So section 6 comes the medication. What are the medications she's getting? Like oxytocin, medicine, IV fluids. If it is oxytocin, she's getting. If she's not getting, tell no. If it is, if she's getting, mark it as yes. Medications if she's getting, yes, and if it is no. So I am saying so much in detail means this has to be put in mind. Only if you are knowing that what has to be put there, we will be doing that. And if it comes to the practice, definitely I could see that in this labor care guide, we are not missing anything about the mother and the fetus. Almost right from her name, parity, address, and her previous history, systemic illness, and her progress in labor, and the medication she's getting, and everything is being included in this. I don't think that anything has been left out here. It is coined in such a way, and it is designed in such a way that we don't miss anything. And the guidance for completing section C is oxytocin, medicine, what are you giving? If the woman is receiving any other medication also, as I previously said, 50 milligram of intramuscular injection is being given. Then section 7, almost, I think this is the last section. This is the shared decision making. There a column is given assessment and planning. Assessment and planning section is given here. And guidance for completing is record the overall assessment and any additional findings not previously documented but important for labor monitoring. Record the plan following assessment, and continuation of routine monitoring, prescription of diagnostics as augmentation of the labor with oxytocin infusion. Intrapartum ultrasound. Now we come to the next modality of intrapartum maternal monitoring. So intrapartum ultrasound is in active labor is not used widely, but even though some study shows that it is more precise and reproducible than clinical examination. It gives some objective measurements and precise documentation, and several sonographic parameters can be used during labor to assess mainly head station and position. Head station, as you all know, head station can be measured objectively by angle of progression or head perineum distance also. It can also help to predict whether we should decide on operative vaginal delivery or we can permit her for labor transfer. Head station should be assessed transperineally, not transabdominally. When this ultrasound is helpful in labor, there are two main situations in which ultrasound assessment is likely to be of particular use in labor: when you suspect a delay or arrest of first or second stage. Potential need for performance of operative vaginal delivery. Simple thing, even if you don't know ultrasound, even if you're not well versed in ultrasound, and I don't know what to see, just keep the probe on the perineum, and if you're showing head perineum distance, that shows the progress of the labor. When it is short, the labor is progressing, but it is long, it has to progress. That's all. So when you are doing a transabdominal ultrasound, the upper thing it is indicated is symphysis, then the skull, anterior part of the skull and the posterior part of the skull. And real-time ultrasound measurement can be seen whenever the patient pushes. The head movement can also be recorded. The obtuse angle in the symphysis and head shows a good progress of the labor. So head position, like when you are using a transabdominal ultrasound, you can see the position of the head. Head position, head and spine position is assessed more accurately. You can even assess the some arrest of occipital posterior position. That also you can assess with the head position with ultrasound. Now, our main target and aim is to have a good maternal care and fetal care to reduce maternal mortality rate and the perinatal mortality rate. That is why we are discussing all these things here. And we could see here that there is a program which is being introduced by a government of India that is called as Lakshya program for pregnant women and newborn, where all this quality, labor room quality and the improvement initiatives are emphasized so that your care and a good outcome of the fetus. Lakshya maintain records and appropriate partogram whenever it is needed. And future, it may also include this labor care program, I think so. So as this vision and mission of the Lakshya is to reduce the maternal and newborn mortality and morbidity, to improve quality of care during the delivery and immediate postpartum care, to enhance satisfaction of beneficiaries visiting the health facilities and provide respectful maternal care to all pregnant women attending the public health. So everywhere they are calling it that they are emphasizing as respectful maternal care, respectful maternal care. It is a must because the patient comes with a lot of agony and she doesn't know mentally also she's not fit to, she's not ready to accept all these difficulties in the labor. So she has to be given a good companionship and a respectful maternal care. So what is the take-home message here is respectful maternal care and to reduce the morbidity. Thank you. I think I have put an eagle's eye view on a partograph and the types of partograph and the advanced modalities in intrapartum maternal surveillance. And I thank our respected director, Professor Vijaya Madam, for giving this opportunity. And I thank our Deputy Director, Professor Dr. Meena Ma'am, and our Associate Professor, Dr. Geeta, who is also a Nodal Officer for Lakshya, for guiding us to make this preparation. And I thank my colleague, Dr. Sharmila, who also guided me in preparing all these things and giving a picture about what to speak and how to go on. And I once again thank every patient audience for watching this. And I think these things will be useful, at least not now, later on when you're starting to use the labor care guide and the maternal monitoring. I thank you one and all. Thanks a lot.
Jayashree, you're on mute.
Thank you, Balaji sir. Thank you so much. It was definitely a very great session. So as we are running short of time, the participants can post the questions and we would love to answer them like within a few days or probably within some time. So you can post your questions on YouTube and we would love to answer them. Thank you to Dr. Vijaya Madam, Dr. Sharmila Madam, and Dr. Balaji sir. Thank you so much. This was a great session, and everybody would like have been benefited from this session. So be it from a healthcare application specialist like me to a nurse or a doctor. So your presentations were completely very great to us. Thank you so much. And
can we
thanks
stop
for
sharing
this
slide? Can we stop sharing the screen? Yeah, thank you.
Yes. Thank you so much, sir. And thank you so much, ma'am. It's been great. Thank you so much.
Thanks. Thank you. Thanks a lot.